Good evening. My name is Lori Rizzuto, and I'm the Executive Director of Behavioral Health Services for Atlantic Health System. I'm delighted to welcome you to our program tonight that's being hosted jointly by the Atlantic Health System Foundations. We'll be addressing a topic that hits very, very close to home for so many people, the significant effect of COVID-19 on our mental health. We're all facing a very new normal in this past year, and whether you've had a loved one who's contracted COVID-19, lost a job, or is just trying to figure out how to live in this new virtual world, it's been very, very difficult. Over the past year, people are experiencing anxiety and worry and nervousness and depression. And now in the past year, because of COVID-19, 4 in 10 adults are reporting symptoms of anxiety and depression, which is really up from 2019, when only 1 in 10 reported those very same symptoms. Our donor-supported programs through Atlantic Behavioral Health help us to offer hope through individual and group therapy or medication management. Through these programs, Atlantic Health System is supporting our neighbors and building healthier communities during these very unprecedented times. And thanks to philanthropy, we're able to expand our services as our patient needs grow. Now tonight we have the following Atlantic Health System psychiatrists here to share their expertise. Dr. Jason Minion is a child and adolescent psychiatrist at Overlook and Morristown Medical Centers and is here to talk about mental health in the youth. Dr. Tamara Lipsky is a psychiatrist at Newton Medical Center and will talk about substance use during COVID. And lastly, Peter Bolo is our chairman of psychiatry at Overlook Medical Center, and he's also our interim medical director for Atlantic Behavioral Health. He'll be talking about social isolation in our older adults. And Dr. Minion, I'll turn it over to you now.
Thank you, Lori, for that introduction, and thank you everyone for being here today. I certainly welcome the opportunities to be able to talk about the mental health issues in youth throughout this pandemic. So at AHS, we have a number of services that sees kids with mental health issues, including outpatient psychiatry and therapy, an eating disorders program, various collaborative care initiatives in pediatric offices, as well as consults in the emergency room and general medical floors. Across all of these services, we've noticed an increase in the number of kids seeking help for mental health issues, as well as an increase in the severity of the mental health issues. And I think there's probably about 3 major reasons why that might be. One, direct stress from the pandemic, lack of access to healthy and normal coping skills, as well as a reduction in the availability and accessibility of services. So I want to look at all 3 of those areas. As far as direct stress goes, some kids have been just stressed out about having a global pandemic. Their whole lives suddenly turned upside down, afraid that they're going to get sick, that their family's going to get sick, that people are going to die. You know, I think also they're worried, is this going to be their entire lives? They don't know where this is going. As adults, we don't know where it's going either, but kids, haven't lived quite as long and certainly don't have a sense. And so many of them are very anxious about the virus. I've seen a lot of kids as well who have taken on a lot of the financial stress that their parents have been feeling. As much as parents try to hide that from their kids, many who have either lost their jobs or had to cut back, it's been noticed by their kids. Another source of stress I've seen from the pandemic is that kids are just around their parents more than they ever were before. Being stuck in the same home just breeds more opportunity for conflicts, where parents can see what their kids are doing every minute of every day. Some of the adolescents don't seem too worried about the virus and have been wanting to go out and do things that by law they're just not really been allowed to do. And that set up even more conflicts with their parents. The kids are searching for independence and the parents are being more restrictive than ever before. And all of this might have been tolerable and kind of worked out okay, but the kids then didn't have access to the normal coping skills they would have used, which ended up creating anxiety and depressive disorders in kids who didn't already experience them and worsened them in those who did. Sleep habits were significantly thrown off by the pandemic, as people just stayed home, didn't have to get up and go to school. That certainly worsened sleep. Staying in the same room all day, every day, makes sleep worse, but also then the lack of exercise that comes with that has been a problem. Some kids that I see wake up in their bed, do school in their bed, and then go back to sleep in their bed, almost never leaving the room. Even just getting up to like physically walk out the door, go to school, walk around the school, walk back into the home. That movement is helpful for mental health. A lot of youth sports and other activities have been stopped, and this was a great place for kids to get exercise. Even gym class became just kind of having to report to the school what you did for exercise and not actually have to do anything. So the lack of exercise has played a big role. Kids are also socializing a lot less than they were before because now they're stuck at home with their families, not around friends, not in the activities where they normally would see other kids. Also noticed a big increase in video game use and playing during the pandemic, in part because there's kind of nothing else to do, especially during the winter when couldn't really go outside. But a lot of parents are feeling, I think, stuck that the kids aren't otherwise seeing friends, and at least on video games, they're talking to other people and to their friends. And so they've been a lot more permissive about letting video games be played than before. And now that it's nicer out, I'm seeing a lot more conflicts of trying to pull back on that. And so those are the kind of coping skills that kids could have used on their own. We've also those seen actual mental health services being really less accessible than they had been. Some of this comes from schools themselves. Schools provide a lot of support to kids with ADHD, learning disabilities, behavioral problems, and even emotional issues. And they couldn't really provide the same accommodations virtually that they were doing in person. This has caused a lot of kids to really just kind of pull back from school. Some won't sign on to virtual classes and have kind of stopped learning this year. A lot of parents as well have been afraid to go into hospitals, afraid of catching COVID there. So if a kid had a more serious mental health issue, even was suicidal, had a suicide attempt, I've seen some families be worried about going to the emergency room or having their child admitted to the hospital. And so they've been trying to manage these issues in lower levels of care that just aren't set up for that level of intensity. There are some mental health programs for kids that are 5 days a week or 3 days a week to provide multiple hours a day of group therapy and intensive monitoring for the mental health issues. And all of these programs have gone virtual this year. And so that loses a lot of the value. For the kids that weren't signing on to school virtually, they're not signing on to do group therapy virtually either. And so it's really been difficult to engage those kids in any kind of treatment. And virtual treatment also just isn't kind of the same in terms of monitoring. A lot of kids were very shy and not willing to really interact virtually. Some of the younger kids were just making faces at themselves in the camera and not hearing a thing I said. So that meant for a lot of the kids who wouldn't go to the hospital and couldn't get the right kind of treatment in these multiple day week programs, we're then trying to manage these serious mental health issues in our outpatient departments. And there we had the same challenges. They're still virtual. It's harder to connect with kids, harder to figure out what's going on. And these kids were otherwise supposed to be needing more intensive treatment. So this ended up creating the effect that there was just sicker kids at all levels of care. And as I mentioned, also, there's been an increase in the number of kids seeking help, partly because those who needed it were needing it more frequently than before, but then also kids who didn't need it before were now find themselves in need. And this ended up creating a backlog in every level of care, from the hospitals to the partial hospitalization programs and intensive outpatient to the regular outpatient programs. Starting to see wait lists that didn't exist before, and this meant delays in getting to care. So, notice overall, then it's been a stressful time for everyone, including for kids. They're struggling to cope and struggling to access good mental health services at all levels of care throughout the entire state. So appreciate everyone for listening to my observations about mental health issues in youth. And I would like to turn it over to my colleague, Dr. Tamara Lipsky. Thank you.
Thank you, Jason. So I'm here to talk to you about substance use disorder, and I'm going to focus my talk tonight specifically on opioid use disorder and the opioid epidemic. I'm going to tell you a little bit about the history of the epidemic, the effect of the pandemic on what was an already existing public health crisis. I'm going to tell you a little bit about the science behind addiction and addiction treatment, and then what we have added on to our programming at Atlantic to address the problem. So I'll start with the history of the epidemic. It began right around 1999 with the increase in prescribing of prescription pain medications. This happened for a variety of reasons. We now know that pharmaceutical companies intentionally misrepresented the danger of these medications, and in turn, we as physicians prescribed enthusiastically. It turned out that not only were opioids tremendously appealing for misuse, but that even when used as they were being prescribed, they were quickly addicting. It takes a 5-day course of opioids to be at increased risk for developing a dependence. During this time, we began to see a sharp rise in deaths from unintentional overdoses. A second wave of overdose deaths began around 2010, having to do with more careful prescribing practices for pain medications and the correlated influx of heroin. As prescription medication became harder to come by, it did create a business opportunity for heroin cartels. Heroin is far less expensive than pharmaceutical opioids and became the impetus for the next surge of opioid deaths. 80% of current heroin users began their use with prescription pain medications and moved on to heroin because they could no longer obtain easily or affordably the prescription pain medications that they were dependent on. In 2013, we saw an increase in the amount of fentanyl in the drug supply. Fentanyl is a synthetic opioid. It can be made in a lab or a garage or a kitchen, as opposed to heroin, which, as you know, is a plant. Fentanyl is between 50 and 80 times more potent than heroin. As fentanyl became more prevalent in the drug supply, the incidence of overdose deaths again rose. This makes perfect sense if you imagine going to buy your general amount of heroin and it's 50 or 80 times stronger, you're going to take too much. My patients tell me that currently in New Jersey, it's essentially impossible to get heroin. You certainly can't get pure heroin, and much of what's sold as heroin is entirely fentanyl. Fentanyl is in everything. The death rate from all overdoses has been climbing steadily throughout this century. Total deaths from 1999 to 2019 surpass 500,000. The rate of rise is not encouraging. From 2018 to 2019, overdose deaths increased 5% from the year before. In the calendar year 2019, 70,000 people died from overdoses. The most recent overdose figures go from August of 2019 to August of 2020. And that number is 88,000. That's a 20% increase in overdose deaths. We're not moving in the right direction. Some of this can be accounted for by the already increasing numbers I just gave you, by the increased prevalence of fentanyl, but the problem has been magnified by the pandemic. We've all experienced the isolation, the boredom, the dreariness of the past year, and substance misuse has increased accordingly. Making matters worse is decreased access to care for an illness where pre-pandemic, it was estimated that less than 20% of people needing treatment for their substance misuse were able to access it. So I do want to talk to you briefly about the science behind addiction and addiction treatment, and then I'm going to tell you what we've implemented at Atlantic starting in the Western region and rolling out throughout the system. So opioids work in a small part of the brain that, for better or worse, is called the nucleus accumbens, and it's located in our primitive brain, which means the part of the brain that we share with all mammals. It's deep in the brain near instinctual nonverbal areas that control learning and emotion. Opioid addiction happens very quickly. As I said, a 5-day course of opioids puts you at increased risk of still being on them a year later. We know that withdrawal from opioids is difficult and painful, but that's actually the easy part of addiction. Opioids damage the pleasure-reward pathways in the primitive part of the brain in a way that persists for years and perhaps permanently. To explain this in terms of an experience we've all had, think about an instance when you've accidentally touched a burning pan. You pull your hand away before you even have the thought that it's burning. That's the part of the brain that controls your actions without you having to think first, and that's the part that's damaged by opioids. Long after the withdrawal process, for years after withdrawal, a person's sense that they need an opioid is coming from the part of their brain that's able to make a decision and initiate an action before their conscious brain gets involved. Opioids act on the part of our brain that has evolved to facilitate survival, and they damage that part of the brain. The bright side of this is that we now understand opioid addiction as a chronic illness. You can think of it like diabetes or high blood pressure, and treating it as such can be very effective. The medications that treat opioid use disorder all work on the same neuroreceptors as opioids do, in different ways that can be monitored and used safely. You've all heard of methadone, which is actually a very effective medication that saves lives when used properly. We also have 2 newer medications that are safe and effective and that can be prescribed at a regular doctor's visit, and that's what we've most recently introduced at Atlantic. These medications are life-saving and life-changing. Relapse rates over the course of a year drop significantly. Someone who withdraws from an opiate and isn't treated with medication has between an 80 and a 95% of relapsing within the first year. Someone who is treated with medication has between a 30 and a 60% of relapsing. It's still significant, but the difference is tremendous. It changes not only the lives of the person being treated, but as some of you've already experienced, the lives of parents, partners, and children. So if this works so well, why don't we have a handle on the epidemic? Of course, there are myriad reasons for this, starting with the idea that substance use and misuse is somehow baked into people's genetics. But the biggest problems are public perception, stigma, and access to care. These are problems in the general public, but sadly in the medical community and in the addiction care community as well, which is part of what makes the program we're developing so exciting. As I said, substance misuse is a chronic illness, and for opioid dependence, medication is a chronic treatment. Our best information now tells us that people need to stay on their medication indefinitely. We hear from patients, from families, from other physicians, that people who are on recommended medications aren't sober, that they're just using a crutch. I urge you to try to think about this differently, to think about addiction the way you think about other chronic conditions, such as high blood pressure or diabetes. We would never suggest that someone come off their insulin or simply suffer the consequences if their glucose skyrockets when they don't manage their diet and exercise. And when they don't manage their diet and exercise, we don't chastise them or turn them away. We tell them to come back, or we don't tell them to come back when their behavior is healthier. We increase the intensity of their treatment and their care. This model of addiction allows us to work with people, support them, guide them toward what their rational brain wants, away from what their instinctual brain, which has been damaged, is telling them that they need. The current recommendation for treatment of opioid use disorder, as recommended by the American Medical Association, the World Health Organization, and all other relevant agencies, is a combination of medication and psychosocial treatment. Medication in combination with psychotherapy, with intensive outpatient treatments, with peer support groups. Every individual suffering from an opioid use disorder should not only be offered, but encouraged to use medication. Again, it's estimated that less than 20% of individuals with these disorders are offered appropriate care. So that's why it's so exciting that over the past year, we've been able to offer this at Atlantic, beginning on the Western campus, but now extending throughout the system. We currently have an active medication program in our general outpatient psychiatry department at Newton, and we'll be beginning that at Morristown in the near future. We've added medication treatment in our substance use intensive outpatient programs at Newton and Hackettstown. We're also creating programs with our emergency room physicians and with our hospitalists at all our sites to identify and appropriately manage these patients when they first present for treatment. Dr. Bolo and Lori Ann have put together a system-wide working group of psychiatrists, internists, obstetricians, faculty from the family practice residency and the internal medicine residency to develop a comprehensive and broad-reaching program to provide respectful, evidence-based, effective care. So that's just a very quick summary, and now I'm going to turn this over to Dr. Bolo.
Thank you so much, Tamara. And I'm really happy to be joining you all tonight because I have the opportunity to talk to you about why older adults are awesome even through the pandemic. So we all know that older adults are more likely to get COVID, more likely to be hospitalized for COVID, and more likely to die from COVID. So we got to assume that the mental health impact of COVID has been more intense and more of a burden for older adults, right? Well, actually, not right. That's wrong. Older adults have actually fared much better under the stress of the pandemic. In fact, the CDC did a study about 8 months into the pandemic, and it showed that in the age group between 18 and 25, that 1 in 2 people experience significant depression, anxiety, or trauma, 1 in 2. Between the ages of 25 and 44, it was 1 in 3 people reported significant depression, anxiety, or trauma symptoms. The little next older group, 45 to 65-year-olds, 1 in 6 reported that. And in the older group, 65 plus, it was only 1 out of 12 that reported substantial depression, anxiety, or trauma symptoms. So there. In fact, there was a really great study done in the US that looked closely during this period of time at 73 averaging 69-year-old older adults who actually had had prior depressions, episodes of depression before the pandemic. And in this really careful study, they actually found that they noted to be withstanding the pandemic isolation quite well. And the authors wrote, depression, anxiety, and suicidal ideation symptoms did not differ pre-pandemic to pandemic. They did note that older adults that they studied were more concerned about their risk of getting COVID-19, and that they did report that their quality of life overall was a little lower, and they were worried about the potential for mental health impact. But they also reported that they were feeling somewhat resilient to the stress of being isolated and the stress of physical distancing. And most didn't really report feeling terribly socially isolated. They did report that they were somewhat outraged by what they found as a group an inadequate response by the US government to the pandemic. So I rest my case. Older adults are more resilient. And I'm going to give you my older adults cheer right now. Go older adults! You can join me if you want. But really, that's not the whole story. I've really been focusing mostly on older adults living in the community, right? There is a subset of older adults who have been differentially very much more affected by the pandemic, and I want to speak about them for a few minutes. So we know that of the 500,000 initial COVID deaths in this country, that 81% of those deaths were in folks 65 years and older, 81%. And that a third of those deaths were people living in long-term care facilities. And we know that people with dementia are twice as likely to get COVID. And in fact, the odds ratio was 2.09 overall with dementia versus age-matched peers who didn't have dementia. And in those Black Americans with dementia, it was nearly 3 times the risk. So we know dementia is actually an independent risk factor, aside from age and aside from other comorbidities. And drilling down on that and trying to understand that, I think there are a number of factors which make logical sense. The first is that one's cognitive impairment limits one's ability to adhere to the public health measures that are necessary, the masking, the staying apart from people, etc. And also the hands-on care that's required for people at later stages in dementia really prevents social distancing. And people needing to be in a long-term care facility setting, unfortunately, given these, the virus was just transmitting in a very rapid fashion and led to some really profoundly upsetting situations and losses. And then triggered, understandably, but unfortunately, a series of very severe lockdowns that caused a lot of isolation for this population. And this population is vulnerable to that. This culminated in a great editorial, one of my favorites, recent editorials in the New York Times on February 21st by Engelhardt. I love the title, "We are going to keep you safe, even if it kills you." For the millions of Americans living with dementia, every day during this pandemic can bring a fresh horror. Geriatricians are seeing an escalation of decline not yet measured. People with dementia are losing things faster than they should. Weight, words, functional abilities, their remaining sense of self. And they have developed more behaviors. They show less positive affect and more negative affect, more apathy and agitation. And I had to share with you that my mom, who's in an assisted living facility in Silicon Valley, I saw this with my own two eyes. As she had lockdowns, she really got much more disorganized. And for the first time in her life, she actually hit somebody who was working with her. Unbelievable. But then the good news, luckily, the vaccine. And of course, vaccines were delivered first to healthcare workers and people living in long-term care facilities. And since December, with the rollout of vaccines, there was remarkably substantial decrease in rates of COVID in long-term care facilities, and subsequently then the reopening of the facilities, allowing people to visit family, friends, etc., have social activities again within the facilities so that people can reorient themselves and move forward more positively. And actually, again, just sharing my own experience from my mom, she's done much better subsequently now that she's able to participate in activities and make friends again. So that's that story. So that is having a happier ending now. But let's go back to that other group of most older adults who are living in the community and try to understand why they're faring better and coping better than younger people are with the stress from the pandemic. So I think a couple of things. Number one, if you look at the developmental phase of where people are in their lives, that can tell you something about what they might be able to tolerate better. So if you think about younger adults versus older adults, younger adults are preparing for work or working. Older adults more likely to be retired or on a fixed income. Younger adults, parenting, perhaps, or preparing to parent. Older adults, maybe grandparenting. A lot easier, right? Younger adults, there's an assumption that they're going to be active. They're going to go out and recreate. They're going to travel, socialize, out, etc. Older adults, somewhat more biased toward being comfortable with being more home focused. Younger adults, certainly much less expectation of loss amongst your peers compared to older adults who are maybe beginning to prepare and adapt to losing some of their peers. So what I think we're seeing here is the younger adults in the more building phases of life are more adversely affected and have more stress related to the pandemic than older adults who are in a more settled or denouement phase of their life. The second thing has to do with life experience and what life experience teaches us. And during the SARS epidemic in South Korea in 2003, there was a great study that spanned 4 years and looked at how people coped, different groups of people by age coped with the epidemic. And what they found was consistent with what I've reported thus far, that older adults experience greater adaptive coping in crisis. And they attributed that to life experience and wisdom. Older adults often develop strengths through a lifetime of experiences and are often better able to negotiate through challenges than younger adults. Perman was the author there. Older adults have a higher level of what's referred to as proactive coping. Proactive coping, that was a new term to me. So effortful steps to modify or avoid a stressful event before its occurrence. Like kind of being prepared, if you will. And how did they get prepared? Well, they studied and did their homework and older adults by and large have greater pandemic knowledge. Secondly, related to that, and trying to prepare and avoid, older adults had better and have better adherence overall to the public health measures that are recommended. Let's talk for a moment about wisdom. Wisdom is a really, really fascinating concept. It's actually considered a neurobiological personality trait, half inherited and half learned over the life cycle. And there are 5 or more separate aspects to it. Those include, first, pro-social behaviors, which are things like empathy, compassion, altruism. Second, emotional regulation, sort of even-temperedness, if you will. Third, spirituality, the sense of some larger meaning in life than oneself. 4, self-reflection or ability to insight. 5, social advising, the ability to give sage advice, if you will. All of these tend to increase with age. And all of these can actually be learned and reinforced over life and are associated with a sense of well-being, happiness, resilience, and less loneliness. And in fact, wisdom is inversely proportional to a sense of loneliness. I want to end tonight by sharing some more good news. And in case you haven't picked up on it, I like to highlight positives. I particularly like to do that right now during the pandemic because this has been a very, very difficult time for everyone, to say the least. So it does feel good to hear some positive words every now and then, right? So I was really shocked when I learned that the CDC's data about suicide in 2020 showed that there was a 5.6% decline in suicide in 2020, the year of the pandemic. I really fully expected the suicide rate to be much higher. And in fact, the suicide rate in this country has been, if it's something that you looked at, has been increasing steadily. So I was really happy to learn that. And I think that there are a few factors involved there. One is the idea that there's something really awful outside of oneself and causes you to focus a little less on the awful things you might be feeling inside. Secondly, is there's certainly been a lot of supports and people reaching out, and that supported some people. And yeah, so let me stop there and turn it back to my friend Lorianne Rizzuto. And thanks a lot for engaging, attending, and listening, and for your philanthropic support. Lorianne.
Thank you, Peter. Thank you, everyone. You can all see why I'm so thrilled to work with these physicians every day. I'm really very, very grateful for everything that they do. Before we go to our questions, I'm going to just give you a quick little overview of some of the services that we have at Atlantic. We have 3 adult inpatient psychiatric units at Overlook, Morristown, and Newton Medical Centers. In each of our emergency departments, we have what we call crisis intervention service. So if someone walked into any of our emergency rooms and they complained of a psychiatric issue, or if they came in and they weren't exactly sure how to name it, they would speak to a nurse at first, get triaged, and then move over to our team. And they'd be met by somebody who is a master's prepared clinician. So sometimes you hear people talk about social workers or a clinician, or you might hear the word therapist. In our team, we're called, all those words mean the same thing to us. So the folks in our crisis intervention service would go ahead and make an assessment and then speak with one of our psychiatrists to develop a discharge plan. It might mean that some people go and get admitted and some people get discharged and go to an outpatient level of care. On our outpatient side, we have what are called traditional outpatient services where people come just individual sessions. Some people come for group sessions, sometimes family, especially as Dr. Minion described for our children. We see parents and their children. We have programs that are called intensive outpatient programs or acute partial programs, and that's where someone would come anywhere between 3 and 5 hours a day for 3 and 5 days a week. And that's a level of care where we try to have people either after they leave an inpatient care, they step down to that level, or instead of going into an admission, sometimes we try to keep people in the community and have them stay at an IOP or a partial program level and try to avoid that psychiatric admission. So we have a pretty full continuum across all 5 of our campuses. And we're always looking for new ways to innovate, new ways to add new programs and services to meet the needs of our communities based on what we're hearing. And so we do have some questions. The first question is going to go to Tamara, and there are 2 for you, actually. The first one, I wonder if you could give us some examples of some opiate medications that people might be prescribed. Because you did mention that sometimes people receive an opioid from their doctor, and just if you can give a couple of names just so people are aware of what they might be.
So, sure, Lori, you're referring to prescription pills that people would get that would.
Right.
So I think, the common ones and things that most of us have actually had, with you get a broken leg, you need a surgery, you have a back spasm. Codeine, Percocet, people are actually prescribed fentanyl and morphine and MS-Contin, but Percodan, those are all medications that I think most of us have had the experience of being prescribed.
Good. And you could also get something like Percocet if you have a wisdom tooth pulled or you have a dental procedure, right? So it's not only if you're having a surgery, but something like going to the dentist. And sometimes that happens with kids, right? Kids have to have their wisdom teeth pulled. Yes. and they're prescribed that. Right?
Oh, absolutely. Children are prescribed opioids as well. Absolutely.
Yeah. So another question for you is, how do people get addicted?
I wish I knew. But it's a good question. I guess the first part of that answer, which seems a little silly and obvious, but is worth noting, is that people get addicted by using substances. And, that's not as silly as it seems. If you never take an opioid, if you never smoke crack cocaine, you're not going to get addicted to it, which then, leads to the next, which is environment. If you grow up in a household where someone is abusing substances, where someone drinks heavily, where a parent has chronic pain and is appropriately using opioids, you have more exposure, more chance of using those things if you, live in a social setting where there's a lot of drugs on the street. So there's that. Biology, genetics certainly play a role. We know that substance misuse runs in families, and some people are certainly, more inclined than others. Mental health plays a role. Upwards of 70% of people who are diagnosed with a substance use disorder have another psychiatric diagnosis as well. Anxiety, depression, more serious psychiatric illnesses. I think one thing, and it matters what causes it. It matters in terms of us understanding, it matters in terms of public health initiatives and prevention. But it's worth noting that once you have a substance use disorder, it has a life of its own. And so sometimes people will think, oh, I started this because I was anxious, because I was depressed. If I could just treat the depression, if I just treat the pain, the addiction will go away. And that's not the case. Once it starts, it needs aggressive and attentive treatment of its own, I think.
Yeah. There are a lot of factors that go into it, and as you mentioned in your talk before, we're lucky that the field has evolved and we have other ways of treating other than methadone is a very old medication, but now we have new medications that we're using and that are very successful and effective. And so it's lovely to see how we're progressing, just like other aspects of medicine are progressing, so is psychiatry.
Yeah, and I would just add one more thing, that not only do we have these new medications, but it's changed our entire attitude towards it and our approach to treating people with substance use disorders. And instead of blaming these people and shunning these people, we're able to welcome them into care and support their recovery.
Yeah, well said. That's true. So Jason, the next question is for you. Look in your crystal ball, and if you could guess for us what you think mental health might be like for kids if, in fact, they all go back to school. What do you think they're going to be struggling with?
Yeah, well, certainly if I've learned anything over this past year is that I need to not, I can't make predictions about the future. Everything I thought at every step is just not turned out to be true. But I do think there's going to be some good and some not as good. To begin with, already some school districts and some students have been getting back to school. And so I've been able to see in those kids that things really have improved. I mentioned some kids who needed the extra services in school in order to engage, either because they needed an aid or because they just wouldn't log on to the computer, but would do it when they're face to face with a teacher. Those kids have done much better and significantly better in their education, helping their self-esteem, seeing other kids again, getting moving again. So I think as more and more kids get back to school, there's certainly would expect a lot of kids to start getting better, even not just schools, but a lot of like sports and activities have been picking up again. On the other hand, there's a whole group of kids that I was seeing that maybe had a lot of social anxiety and struggled before the pandemic to be in school. Just being around that many people and being around kids who might not be so nice was a real struggle for them. And before the pandemic, a lot of these kids would at times try not to go to school. And the solution there is to do everything we can to get them into the school. We know that every day we let them stay out of school and avoid that anxiety, it becomes that much harder to ever get them back into school. And now for the past year and an extra marking period, they've been allowed to be out of school. And even if their school district went back in person, most of them have opted to stay virtual. So I foresee in September, if they're going back to school, this group of kids they're really going to struggle. It's going to be a lot of anxiety, a lot of hesitation about getting back into school. And it won't probably be the same school. I imagine, I don't know if there'll still be mask mandates or not in school, but if there are, that adds another layer of anxiety for these kids.
Good, thank you.
Yeah.
I wonder if you could, oh, I'm sorry. I wonder if you can just comment on what are some of the signs that parents can look for in their children? If they see what, should they seek out a pediatrician or a psychiatrist? What should they look for?
Yeah, so and there certainly are going to be some signs, but generally, I think a lot of parents can get some sense that if something just doesn't feel right, if the kids seem different in some way, we know so if just their mood seems to change, like even as simple as that sounds, but their demeanor changed. They seem more down where they used to laugh. If they seem to not enjoy the same things that they used to enjoy playing, that part has certainly been more difficult because kids have been taken away from the things that they would normally do. And so we can't see them not engaging because we're just not given the opportunity. But still, to some degree, that is the case. And as new activities come back online, in a sense, parents see the kids not looking for that. That would be a reason to be concerned. Grades dropping are another key indicator that maybe the kids are less motivated. They're distracted by being more depressed, more anxious. And I think anytime the parent has concerns, certainly the pediatrician is a great person to bring these concerns up with. Pediatrician can spend time with the kid to try to understand what might be going on, and then they can help them to access any mental health resources that might be needed.
That's great, thank you. And Peter, the last question is for you. How could we help reduce loneliness in seniors?
Wow, that's a good question. So, Vivek Murthy, he is the former and now the present Surgeon General of the US. He really brought to the fore for us what he refers to as the epidemic of loneliness in this country. And he was able to define with supportive data that the risk of dying related to loneliness is equivalent to the risk of dying from smoking 15 cigarettes per day and more than the risk of obesity. Are older adults more likely to suffer from loneliness? Good question. Really not. Actually, studies show that loneliness peaks at various phases of life. The first one, and this sort of surprised me, was in the late 20s. I think people kind of leaving home, getting out onto their own work, partnering, etc. It's a tricky phase of life. The second one is mid-50s, a peak of loneliness in mid-50s, which kind of made sense to me in terms of like empty nest kind of related things and transitioning in phase of life. And then the third period of life where people have more loneliness is in the late 80s. And I think what happens in the late 80s that's makes people feel lonely as they start to lose their generation, really. So being older is not really equated with being lonely. And we know that older people have more likelihood of being wise and acquiring wisdom, and loneliness is inversely proportional to wisdom. And finally, I saw a really interesting study recently that looked at people who were receiving Meals on Wheels services, older adults, and they had the folks in the study called like a short 5 or 10 minute call from a younger adult who had very minimal training, just sort of a social pleasantry kind of call. Hi, how are you doing? And they were called 7 days a week for a week, and then they were called once a week for a month. That group of people who had the calls versus the people who didn't get the calls reported substantially less depression and anxiety and isolation and loneliness. So that's kind of a simple intervention.
Yeah. So something as simple as reaching out to those in your family, and whether the person is older or younger, but just making that connection. Maybe it's a text, maybe it's a FaceTime. I know in my family, I've had to teach my parents how to FaceTime because they weren't used to doing that, but maintaining that connection in any way possible.
Yes.
Yeah.
Absolutely.
I wonder if our speakers have any other last thoughts? Any last? No? Well, thank you everyone for being with us tonight and supporting our Atlantic Health System Foundations. A recording of the presentation will be sent out as soon as possible, probably within the next few days. Be sure to reach out to your respective hospital foundations to find out ways that you might be able to support mental health in your communities. Thank you very much for listening. Thank you for your support. Be safe and be well. Thank you.